Hey everyone, and welcome to this explainer on the 2022 RCOG Green-top Guideline No. 74. If you're an MRCOG candidate, you're going to want to pay close attention because this is an absolutely essential high-yield document. We're going to comprehensively unpack the guidelines covering antenatal corticosteroids, breaking down exactly what you need to know for both your clinical practice and, of course, for exam day. This specific guideline updates previous protocols from 2010, and it is literally your definitive source material for understanding how to reduce neonatal morbidity and mortality. It perfectly supplements the NICE guidelines on preterm labor, and it's the ultimate authority on when to give steroids, when to withhold them, and how to navigate those really tricky clinical gray areas. To make this super easy to digest, here's our agenda. 1. Core benefits and evidence. 2. Gestational age action plan. 3. The term cesarean dilemma. 4. Special clinical circumstances. And 5. Dosage and route protocols. Okay, Section 1. Core benefits and evidence. Let's get right into the foundational data. For the exam, you absolutely have to lock in the fact that we have grade A evidence, backed by a massive Cochrane systematic review of over 11,000 women, that corticosteroids drastically improve outcomes when given within 7 days of preterm birth. Specifically, they reduce perinatal death, neonatal death, and respiratory distress syndrome. The really interesting part here is that the optimal window of benefit is strictly within that 7-day period, especially if birth occurs 24 to 48 hours after starting treatment. Also, keep in mind there are no direct beneficial effects for the mother. This is entirely about fetal long maturation and neuroprotection, which includes a significant reduction in intraventricular haemorrhage. To put this grade A evidence into a really sharp clinical perspective, let's talk about the number needed to treat. To prevent one single perinatal death in patients between viability and 34 weeks, the number needed to treat is just 43.5, and for respiratory distress syndrome, it's even lower at 23.3. That demonstrates an incredibly potent, highly likely clinical benefit, which perfectly justifies why this is such a cornerstone of obstetric practice. Moving on to Section 2, Gestational Age Action Plan. Think of this timeline as your mental roadmap for the boards. At 22 weeks, when active care is deemed appropriate, we start having those stabilization discussions. The absolute prime grade A window, that runs from 24 plus 0 to 34 plus 6 weeks. Then, as we move into the late preterm window at 35 weeks and the early term window at 37 weeks for planned cesareans, those routine offers stop and custom risk-benefit discussions have to take over. So, the crucial takeaway is this. You must offer steroids to women between 24 plus 0 and 34 plus 6 weeks when an imminent preterm birth is anticipated. And that applies across the board, whether that imminent birth is due to established preterm labor, preterm prelabor rupture of membranes, or a planned medical intervention. In this specific window, the benefits heavily outweigh the risks. Section 3. The term cesarean dilemma. This is where things get a bit more nuanced. We're looking at a classic clinical trade-off here. Once you cross that 35-week mark, the risk of severe respiratory distress naturally drops. In the late preterm window, up to 36 plus 6 weeks, giving steroids is likely to reduce the need for respiratory support. But, and this is a big but, you are now significantly increasing the risk of neonatal hypoglycemia. Fast forward to a planned cesarean between 37 plus 0 and 38 plus 6 weeks, and the benefit shrinks even further. You might decrease neonatal unit admissions for respiratory morbidity, sure, but you risk causing neonatal hypoglycemia and potential developmental delays, specifically a reduction in educational attainment at school age. Which perfectly aligns with the guideline stance on planned cesareans at early term, because the overall risk of respiratory morbidity at term is low, only around 5%, and usually mild. This is a grade B recommendation. It strictly dictates that an informed discussion has to take place with the woman. You literally cannot just prescribe it routinely, because the actual reduction in respiratory distress syndrome or transient tachypnea at this stage is genuinely uncertain, while the risks of hypoglycemia are very real. Section 4. Special clinical circumstances. This is exactly where exam questions will try to trick you. So think about this clinically for a second. How do our clear-cut grade A guidelines shift when we throw a patient with diabetes into the mix, where steroids can drastically spike blood sugar, or twins, where the physiological load is totally different, or PPROM, where infection risk is a major concern? All right, here is your rapid-fire checklist for the MRCOG. First up, PPROM patients definitively still get steroids. That's a solid grade A recommendation. Second, multiples do get them, but strictly targeted for early birth. You never, ever use untargeted, routine, repeat courses in twins because of potential harm. Third, diabetes is not a contraindication, but you absolutely must give additional insulin via an agreed protocol because maternal blood glucose is going to rise and stay elevated for up to 5 days. And finally, a highly critical good practice point. Never delay an urgent, necessary birth for fetal growth restriction or preeclampsia just to administer a full course of steroids. The health of the mother and baby in front of you always takes priority. Looking closer at the source data for multiple pregnancies, there's actually very little direct evidence of benefits specifically isolated to twins, which is why it earns a grade D recommendation. But we assume the mechanism is the same, so we treat them in line with singletons for an initial targeted course. Just remember, the data actually points to potential harm, like increased neonatal intensive care admissions, if you administer unnecessary, untargeted, repeat doses in these cases. Section 5. Dosage and route protocols. Let's talk pharmacology. Let this number completely burn into your memory. Regardless of the specific preparation used, the total target dosage of corticosteroids for fetal lung maturation is always exactly 24 milligrams. So how does this look in practice? Well, in the UK, dexamethasone phosphate is the recommended standard. It's soluble, it doesn't require refrigeration, and you hit that 24 milligram total by giving it intramuscularly as either 2 12 milligram doses 24 hours apart or 4 6 milligram doses 12 hours apart. An acceptable alternative is the betamethasone sodium phosphate and acetate mix, giving us 2 12 milligram doses 24 hours apart. Notice the common denominator here? Both options rely strictly on the intramuscular route. And just to avoid those classic trap options on your exam, note that oral or direct transplacental administration is never recommended. There is simply insufficient evidence to support these routes, making this a firm grade B recommendation against their use. Stick exclusively to the IM protocols. So as we wrap up this explainer, I want to leave you with a practical challenge. Ask yourself, when you were face-to-face with a patient at term getting ready for a planned cesarean, are you fully prepared to communicate these incredibly nuanced risks? Can you accurately explain the uncertain respiratory benefits against the very real risks of neonatal hypoglycemia to ensure the absolute best possible outcome for both mother and child? Mastering that conversation, bridging the gap between the data and the patient, is exactly what separates a good candidate from a truly great clinician. Thanks for hanging out with me today, and happy studying.